So thank you, SAGES, provided opportunity for us to present our work. Today, I would like to talk the revisional surgery after failed adjustable gastric banding, the institutional experience in the 90 cases. So I have nothing to disclose. We know that adjustable gastric banding is a popular restrictive procedure, and this is a safe procedure, and it carries no micronutritional deficiency. However, the device needs frequent adjust, and insufficient weight loss and device-related complications always lead to the revisional surgery. The problem is what we should do for the revisional surgery and which timing we should do. Should we do a gastric bypass? Should we do a sleeve gastrectomy? And we remove the band and do the revisional surgery at one time, or we remove it and wait an interval and do the revisional surgery in two stages. Well, the gastric band has well discussed. The gastric bypass has well discussed, and they provide good results and have very higher complication rate compared to the primary root-wide gastric bypass. How about sleeve gastrectomy? There is no sufficient data available for the revisional results of the sleeve gastrectomy and the timing for the revisional sleeve gastrectomy. So we will focus on the two major questions. First, is there any difference between the revisional gastric bypass or sleeve gastrectomy? The second is, should we perform it in one or two steps? And the second, we will analyze the results of our revisional surgery, because we know from the primary bariatric surgery, the ICU staying and the hospital stays a little bit higher than the primary procedure, and the perioperative complication is around 6 to 50%. And in literature review, the two-stage surgery seems to provide some benefits. It reduced the anastomotic stricture rate in gastric bypass, and it reduced the leakage rate of sleeve gastrectomy. And then we also analyze the factors that will affect the results of the revisional surgery, because we know that for the primary bariatric procedure, they will have a suboptimal weight loss in the elders, male, and patients with higher BMI. So from 1996 to 2011, there are 243 bands placed in University Hospital of Strasbourg. During the same period, 130 bands were removed. The patients will come from our unit and refer from other hospitals. This is the reasons that we need to remove the band. So 71% of them was due to poor weight loss results, and 29% was due to the device-related complications. The complications include the food intolerance, tube disconnect or obstruction, band loosening, or intragastric erosion, so on. So of the 130 patients, 90 of them underwent revisional surgery. We have 2 patients fail to the revisional surgery, and 88 was success. This includes 48 sleeve gastrectomy and 40 gastric bypass. 1/3 of them was done in one stage, and 2/3 of them underwent two-stage surgery. So this is the patient's characteristic. We see that there's no difference of the gender, age, and BMI between the root-wide gastric bypass and sleeve gastrectomy. Also, there's no difference between the reasons that's why we need to remove the gastric band, and there's no difference between the one-stage or two-stage surgery between the two procedures. Let's see our results. We have one perioperative complication. This is a patient we do the revisional sleeve gastrectomy with staple line leakage. And the leakage site is not the common site near the EC junction. This lower part of the sleeve gastrectomy, and we go inside and make the suturing, and the patient was discharged smoothly. During our follow-up, there are 10 additional complications observed. Yes, we have one gastrojejuno stomy stricture, and the patient has to do the endoscopic dilatation. In the post-operative month 12, the average weight loss is around 52, and we saw that the gastric bypass has a slightly better weight loss result. However, there is no difference. And then we analyze that what factors will influence the HCS weight loss result. So it's similar to the primary procedure that the males age over 50 or the patients with higher BMI, they will have an inferior result of the weight loss. However, we also note that very interesting, if the patient has a longer gastric band placement, they will have an inferior weight loss result. And regarding to the type of revisional surgery, the indication to the remove of the gastric band and 1 or 2 stage surgery, there is no difference between for the HCS weight loss. So we try to explain that why the revisional surgery has an inferior result comparing to the primary procedure. Because in our institute, our primary root-eye bypass and sleeve gastrectomy has around 80% of HCS weight loss. So first, we think the gastric pouch or the gastric tube size is probably the one reason. Because when we perform the revisional surgery, we always try to avoid stapling on the dense fibrotic tissue of the previous gastric band. So we think the gastric tube or the gastric pouch probably is larger than the primary procedure. The second is the psychological status of patient, because we always educate the patient to have a good diet quality to exercise, but the patient's compliance is poor, then they will have a poor result. So if we carry on another procedure, if they don't have the good compliance, this also carries with poor weight loss result. So this also could explain for why the patients has longer gastric band placement and they will have the poor results. So in conclusion, revisional surgery is safe and feasible. There is no difference regarding to the surgical procedure and the timing of our approach. And in our small number and retrospective observation, we found that patients with age less than 50, BMI less than 50 kilo per square meter, and the female gender, and the patients with gastric band in place less than 5 years, they will have a better weight loss result. Thank you for your attention.
Thank you for that interesting paper, Dr. Roslin.
Thank you very much. I think it's a wonderful review. I think there is an additional conclusion that I think we should all note, and that is that the band is not a reversible procedure. As Raul Rosenthal likes to say, it's removable. And the scar tissue in the dense pseudocapsule that's there certainly does compromise your revision to some extent, and other things, as your study points out. Paresh and I were just talking, and I will say that we have a lengthy experience, and I will say that it's funny, long-term, the DS patients seem to do very, very well with revision from band to DS.
Thank you.
One additional question. Over the course of your study period, there were 243 bands placed, and almost half of those were removed over that time period. Do you still offer gastric placement of the band as a primary weight loss procedure?
Sorry.
Do you still do the gastric band?
No, we only do in very selective patients, like the very high comorbidity or some patient with some other disease. No, it's not possible to do the other procedure.
Okay. Briefly, Dr. Shah.
Quick question, Paresh Shah from New York. I really enjoyed that review. The one new data point that you seem to have brought out is the time of duration of band correlating with likelihood of revisional success. That is relatively new in what people have talked about with band revision. So you didn't have enough data in your series to make that, I think, really powerful statistically yet. But where do you think the cutoff is? Do you think it's just 5 years?
In 5 years? Because the length of the band placement mean is 64 months and the median is 60 months. So we decide in 5 years for the cut point.
Thank you for that presentation.
Thank you.